My remit is to talk to you for 20 minutes, really as a basic introduction to Polycystic Ovary Syndrome. Of course, you're the experts, especially if you're here with the condition or having a family member with the condition. So I think we as the medical profession are here to learn just as much as we are to tell you, share our own knowledge. But the aim for the next 20 minutes is to attempt to answer the following questions. Firstly, what is Polycystic Ovary Syndrome? And I saw Rachel, who's the chair of Verity, who I didn't know this, but apparently there is a move to try and change the name, because it is actually a pretty rubbish name for the condition, because it suggests you need a scan, whereas it's all about the patient and not the scan. What do we think causes it? And you've just been introduced by, I've just been introduced by Steve Franks, who's been a huge contributor to this field in terms of the genetic and environmental causes, and there are more questions than answers. And why do the symptoms occur? What is the mechanism of why this condition causes the symptoms that you might be suffering from? So firstly, what is it? Well, the main thing is it's a clinical diagnosis. So it's not a radiological diagnosis. And it's based on a patient's story, not just a scan. So I think that's the first thing to say. So let's just give a typical patient who would come to see me on a Thursday morning up at Leicester, and I'm lucky enough to train in London and trained at the Samaritan Hospital. So this area of London has a huge history in terms of reproductive medicine. The Middlesex, which is just down the road, the doyen of reproductive endocrinology was a chap called Howard Jacobs, who had a bright young man called Steve Franks come and work for him at one stage. So this is the part of the world which is really where a lot of work has emanated from. So Emma, she's a 21-year-old student. This is a typical story, who's had acne since puberty, that she went into aged 11 years of age. She's always had unpredictable periods, maybe 5 or 6 periods in a year. This is her skin. She suffers with acne, and she's noticed ever since the age of 13 she's had dark, coarse facial hair, and the symptoms have been getting worse while she's been gaining a bit of weight at college. She started doing all the things that students do, drinking. And so really, Polycystic Ovary Syndrome is one of those sort of the customer is always right conditions, whereby it's only a problem at a stage of life if there is a clinical problem. So there are many patients with Polycystic Ovary Syndrome who never go and see a doctor because they don't perceive their symptoms of a problem. But at this sort of stage of life, the typical things that we would see in clinic would be the cosmetic issues, because people don't like their spots and the hair growth, and we'd be dealing with that. And perhaps at a younger age at school, mum's worried because her daughter Emma's not having regular periods, whereas all our mates are. So something about peer, how you are compared with your peers. And mums are always worried, especially in Leicester where there's a big Asian population. Mums are always worried whether their daughters are going to be able to have children later on in life. That's always an issue. So that's that stage of life. Then Emma is 28, she's graduated from law school, she's got married, and she's been trying to have a baby for a year to no success. So that's the next problem, and so she's been referred to the fertility clinic for further evaluation. So this is a common thing that's seen in this sort of range of life, is the ability to become pregnant. And I think one of the things I want to stress is that Polycystic Ovary Syndrome is a condition of subfertility, it's not a condition of infertility, okay? So the outlook is remarkably good if treated in the right hands. And that's obviously a big worry for people if they have the conditions, whether they can have children. So our case study, Emma has gone on to have 2 children. The first was assisted with clomiphene, relatively straightforward treatment, albeit it needs to be done under specialist care. And the second, she had a spontaneous pregnancy. And this seems to be something that we see in clinics. Patients need a bit of help with the first pregnancy and then manage to get pregnant second time round. But she developed gestational diabetes, so she developed diabetes in both pregnancies. That's very common. And I'm sure throughout the day we'll talk about the metabolic risks of having Polycystic Ovary Syndrome. She's now 48, so we're going through her life very quickly. I'm sure there's a bit of water under the bridge between 28 and 48. So she's put on a bit of weight, and she's gone to see her GP, and she's developed pre-diabetes. So borderline diabetes, that's a whole minefield in itself. What does that mean? Her blood pressure's a bit high. Her cholesterol's a bit high. And so at this stage of life, it's more about the metabolic issues, in other words, the risks of diabetes and the risks of high blood pressure, And then you might wonder, if you've got a high blood pressure, diabetes and high cholesterol, whether there might be an increased risk of heart disease. And in fact, a few months ago, Professor Franks and Jerry Conway, who's another doyen of reproductive endocrinology, held a whole session for doctors on polycystic ovary syndrome, and I had to give a talk on whether there was an increase in cardiovascular heart attacks in patients with polycystic ovary syndrome. In other words, is EMA increased risk of having a heart attack later on in life? In fact, all the studies are quite reassuring. In fact, one of the only ones that shows a slight increased risk is the ones that we did in Leicester, but that's still a moot point. So, you'd want to control all the risk factors to reduce your risk anyway, but it's not clear that there is an increased risk of heart disease. So, just to finish the first bit, polycystic ovary syndrome is a diagnosis based on a constellation of symptoms. That's what a syndrome is. It can cause problems at different stages of life, depending on where you're at. It's got associations with other conditions, and by that I mean diabetes, blood pressure, cholesterol. If you have no periods at all, or less than 4 periods in a year, there is a risk of endometrial hyperplasia and womb thickening, which can predispose to, in the worst case scenario, to endometrial cancer. So it is important to have some progesterone and cycle regulation, but you'll hear about treatments later on in the day. There is a risk of having sleep apnea, which is a condition where people feel knackered in the daytime, fall asleep if you're a passenger in a car, because if you're carrying a bit of weight, there seems to be some evidence that polycystic ovary syndrome, there is slightly increased prevalence. This is a very common condition whereby people snore and stop breathing at night and you get unrefreshed sleep, and that causes people to feel very tired. And when you treat that, people feel dramatically better. So that's underdiagnosed and underlooked for in clinic. There's a big psychological component, and there's a lot of work being done about the effect that the condition has on people's mood. And as I've said, there's some evidence it may increase the risk of cardiac disease because of the risks. Polycystic ovary syndrome is an ancient disorder. In other words, it's been around for years. So this bloke, Hippocrates, so we all have to say our well, I don't think I did say it when I qualified, but every doctor is supposed to say the Hippocratic Oath, so he's the godfather of medicine. He described quite a long time ago, 400 years BC, that those women whose menstruation is robust with a masculine appearance, nor do they become pregnant. It's quite an old-fashioned, but maybe that's one of the first descriptions of polycystic ovary. Then there was some chap, Italian geezer, called Vallisneri in 1721, who described a married infertile woman with shiny ovaries, with a white surface and the size of pigeon eggs. So, that's a shiny ovary. Actually, I nicked that from a Steve Franks paper. And that's a pigeon's egg, which I had to look that up, but that's about 3.5 centimetres, slightly enlarged ovaries. But these are the chaps that really broke through the whole thing in terms of the history of polycystic ovaries. It used to be called Stein-Leventhal syndrome. These are American doctors who, in 1935, wrote a seminal paper in the American Journal of Obstetrics and Gynecology, and it was entitled Amenorrhea, which means no periods, associated with bilateral polycystic ovaries. And they really were the first people to tie together the concept if you had multiple cysts in your ovaries, increased hair growth, and irregular periods. It was part of a syndrome. And actually, Professor Franks is going to talk about the diagnostic criteria. But really, 80 years later, from this paper, the diagnosis is really still based on these 3 things: the presence of morphological changes in the ovary, something to do with testosterone, and something to do with ovulatory function. So it was a pretty, 80 years ago, they got it right. And so I really feel I can't give this talk without talking about this chap, Howard Jacobs, who was Professor Franks' mentor, and I was the editor of the Endocrinologist magazine, and one of the things I did was go and talk to the greats, and he's a very, very charming and amusing chap who's doing a PhD now in Disney studies, and he showed me his home cinema, and he's a very, very, but he really helped understand the whole, and he had actually it was a community midwife that he was working with who developed a technique for ovarian ultrasound, and he said it was amazing. When women went through puberty, you could see the changes in the ovary. So he described the very early changes, and then there was something about high prolactin having problems with conceiving, so we got this chap Steve Franks to do research with him. So the 2 other people I think that in this part of the world we should really acknowledge are Jerry Conway and Steve Franks, and they're all very active to this Royal Society of Medicine, because they've done seminal work on polycystic ovary morphology and the relationship between weight and menstrual irregularity, infertility, and insulin resistance and testosterone. So I think they do need a nod in this place. The other thing, polycystic ovary syndrome, is it's very common. So 25 to 30% of women have polycystic ovaries on a scan, but that's different from having polycystic ovary syndrome. That's just a scan. There are, if you grab 100 women walking the street and you scan their ovaries, apart from wondering what you were doing, about 30% would have morphological changes. But it's a dynamic situation. It doesn't mean they've got polycystic ovary syndrome. The clinical diagnosis, as Stein and Leventhal said, you need something to do with the male hormone testosterone and something to do with ovary dysfunction, where there's irregular periods or difficulty getting pregnant. About 10% of all women, so it's still really common, have this condition. And if you use broader criteria, it's probably more like 20%. So how you diagnose it depends on the criteria used, which Steve is going to talk to you about. So there must be something about this condition which is not all bad, or it would have sort of been eliminated from now. And actually, very interesting, if you look at this, there are evolutionary advantages of having this condition, because if you have polycystic ovary syndrome, you have the greatest capacity for energy storage. And there's a lot of metabolic studies to show that you metabolize brown fat slower if you're insulin resistant. And we can talk about these concepts if there's time. But basically, in areas that are prone to famine, Africa, India, or wherever your ancestors are from, if you lose weight too quickly because you've got no food, the first thing that happens, you see this in athletes and gymnasts and very skinny people that have very low body mass index, the first thing that happens is periods stop and you can't pass your gene on to the next generation. And because polycystic ovary syndrome is a condition of subfertility and not infertility, actually storing energy efficiently and having a smaller family at a time evolutionarily in the past where there's food scarcity actually has advantages, because you bring up a small family and you can provide for them. The problem is, hundreds of years later, now we've got cross-pollination, and Leicester is a classic example of how there's no shortage of high-energy rich chapatis and curries with an Asian family with a gene for insulin resistance. What was a protective gene in one geographical environment now becomes a pathological gene, and that probably explains the increased risk of diabetes and polycystic ovary syndrome in certain ethnic groups, and we see a lot of that where I work. Which brings us nicely on to the second bit of the talk, which is the causes. What causes it? So there's some genetic cause, but we've already said it's the combination between genes and environment. So the sorts of genetic studies that get done by doctors are family studies. Does it run in the family? So there is a familial tendency, just like there is with diabetes. And interestingly, your male siblings of women with polycystic ovary syndrome, in other words, brothers, are more likely to have heart disease. And actually, the sisters of men with heart disease are more likely to have polycystic ovary syndrome. So there is some kind of familial tendency. Twin studies are always useful. So this is these are identical twins. The person on the left smokes and the person on the right doesn't. So it's a very good example of what happens. Twin studies are brilliant ways of trying to work out what causes what in terms of environmentally. And actually, I wish I'd taken a photo. I've got two, they're not twins, but they're sisters. And one was born slightly prematurely and has asthma, and she has they look really similar. I don't think they're twins, but one has polycystic ovary syndrome and one doesn't. They always come with each other, and they're a brilliant example of how environment and gene changes can really interact to cause a condition. You can also be a clever doctor like Steve Franks or a geneticist and say, I wonder what gene is likely to cause this condition, and have a look at whether there's a change in that gene. So that's where you look at a candidate gene. You make up in your own mind what you think the likely gene is, and that's one way of studying it. And these days there are amazing machines called microarray machines where you can look at hundreds of thousands of genes at any one time with gene chips and look at huge numbers of genes with huge number of families. That's called gene-wide association studies, and it's like a fishing expedition, but you come up with certain genes that you may never have thought of. So the current thinking about genes is that there's no single gene. Certain gene associations have been found, some that make sense, like to do with the pituitary gland or the insulin receptor. Some don't make any sense. They look like apparently random proteins. That's with the gene-wide association studies. And the answer is probably lots of genes contribute, just as the causes of high blood pressure and diabetes. So then the environment. There's no specific environmental substance. Some medications like anticonvulsants, anti-fit tablets, there's a tablet called sodium valproate, which can increase the prevalence. But obesity is the biggest environmental risk. So anyone carrying weight on the tummy, abdominal fat is much more risky cardiovascularly than the pear shape. And that's partly genetic. So it's likely to be a combination of genes and environment. So just for the last couple of minutes, the mechanism, why do people get the symptoms? Well, it's partly a problem of the hypothalamus and the pituitary gland, which is within the brain. So the hypothalamus produces a hormone called GnRH, gonadotropin-releasing hormone. This has a pulsatile mechanism and speaks to the pituitary gland, which secretes two hormones which control the ovary. And it is thought that there's an increased frequency of the pulses in the hypothalamus, which increases the hormone called LH, which stands for luteinizing hormone, compared to follicle-stimulating hormone. This drives the male hormone from the ovary and causes multiple follicles, which you see on the scan. So some people think it's primarily a problem of the top end of the hypothalamus. Other people think it's primarily a problem with the ovary. So what's happening in this ovary is a whole lot of stuff to do with steroid metabolism. So what's happening is male hormones, testosterone, and another hormone called androstenedione, which is typically quite elevated in polycystic ovary syndrome, is converted into estrogen. There's a state of flux, and there's an enzyme called aromatase. And there's some thought that there's a relative deficiency in this enzyme in polycystic ovary syndrome, so you get loss of conversion of the male to the female, so that's the cause of the increase in the male hormones. And then this is where Steve Franks has done a huge amount of work, is insulin resistance. What is insulin resistance? Well, insulin, we all know, is important for diabetes. People with diabetes take insulin. But the insulin receptor is like a key going into a lock. There's some problem with the key going into the lock with insulin, which causes, at a very early stage in life, increased levels of insulin. And this is when I was at medical school, we used to learn Starling Law of the heart when people went into heart failure. This is the Starling Law of the pancreas, whereby at some stage the pancreas says, oh, hang on a minute, I can't do my job. And that's when you get diabetes. But there's a whole load of water under the bridge to cover early on in life where you're hyperinsulinemic. And actually a very early sign of this is polycystic ovary syndrome. And this is a slide nicked from, I think, Steve Frank when I was at Mary's. Steve Robinson gave me this, one of my consultants, is the fatter you are, the more likely you are to have high insulin levels. And if you've got polycystic ovary syndrome, that's a combination, so it's a cumulative effect. So if you're overweight, you're more likely to be insulin resistant. And it's thought that insulin increases LH pulsatility, increases testosterone, and also increases the amount of free testosterone that's carried around in the blood, which increases the symptoms. So all this explains the link with diabetes and other metabolic factors. And that's a fancy diagram from the New England Journal of Medicine showing exactly what I've showed you. This is the hypothalamus, this is the ovary, and this is the effect of insulin resistance. So, if the slide changes. In summary, Mr. Chairman, Mrs. Chairman, polycystic ovary syndrome is a very common problem. It can cause symptoms at different stages of life. Treatment's only actually needed if there's a problem. It's likely to be caused by a combination of genes and environment, and it can be associated with other conditions that are preventable, such as diabetes. And just to quickly remind you, the talk was to attempt to answer the following questions. What is polycystic ovary syndrome? We've covered that. What do we think causes it? We've covered that. And why do the symptoms occur? We've covered that. So thank you very much for your attention.